It's 8 o'clock, so we can get started on our grand rounds. And it is my pleasure today to introduce our speaker, Dr. Michael Karsy, who will be discussing the updates on the management of brain and spinal cord injury. Dr. Karsy obtained his MD PhD at New York Medical College. He subsequently went on to do his residency in neurosurgery at the University of Utah, where he also did a fellowship in complex and minimally invasive spinal procedures, as well as obtained a master's in bioengineering, specifically medical devices developed at the University of Utah. He then proceeded to do a fellowship in minimally invasive and open skull-based surgery at Thomas Jefferson University. He is currently an assistant professor at the University of Utah in neurosurgery, neuro-oncology, and skull base. He treats a variety of tumors and spine pathologies through minimally invasive, endoscopic, and traditional open microsurgical approaches. Dr. Karsy is well experienced with radiosurgery and a variety of complex cranial pathologies. He has tremendous commitment toward academics, which is readily apparent from his vast CV. He was the course director of multiple residency training courses and has authored and co-authored over 160 publications, 12 book chapters, in addition to co-authoring his own textbook, The Surgical Handbook. He is involved as a co-investigator on several trauma, critical care, and neuro-oncology clinical trials. I am also so very excited to announce that Dr. Karsy will be joining the GNI family in November of this year. His expertise in spine and skull-based procedures will be a great welcome and a perfect complement to our vast neuroscience practice. So without further ado, Dr. Michael Karsy.
Thank you, Dr. Liebman, for that kind introduction. And I'm super excited to meet the rest of the gang and begin working with you guys. Let me share my slides real quick. So as Dr. Liebman was saying, yes, I've got sort of an extensive sort of background in different training. I do a lot of neuro-oncology, but I also have pretty general practice. And traumatic brain injury and spinal cord injury was something we thought would be very useful for this audience, because it's something that really touches everybody. It touches patients, it touches families. It's something that every neurosurgeon, every healthcare provider kind of sees. So it's something we thought worthwhile to discuss. These are some of my disclosures. None of them are really relevant to this talk. I thought we'd talk a little bit about some of the recent pathophysiology of brain and spinal cord injury, as well as some of the up-and-coming clinical trials, impact management, and also talk about some of the research we've done here, if there's time at the end. These are just some of my cases here. Traumatic brain injury is a very common pathology. About 2 to 3 million injuries occur a year, and about 50 to 60,000 deaths occur annually as well. These peak in youth as well as in the elderly, and peak in the youth due to violence as well as accidents, and in the elderly, oftentimes falls are a common cause of traumatic brain injury. Also, the increased use of anticoagulation certainly confounds and makes more challenging the management of TBI. Just a couple slides on mild TBI, I think that it might help the audience. I hope it helps the audience. Mild TBI doesn't really have a great definition. We think of it as a concussion. There's various degrees of defining what a concussion is. Some things that I found interesting and might be helpful to your patients is that, about 20% of patients have symptoms after a mild TBI a month out. Some may have symptoms even 6 to 12 months out. These are oftentimes things that require reassurance of patients. Many times require evaluation after a trauma to be able to see if they require rehabilitation, physical therapy, speech therapy. These are not uncommon things for even people with mild concussions. Typically, people have recommended rest for a period of 1 to 2 days, but there are medical treatments that can be used for management of headaches, sleep disturbances, and some of the psychological stress, memory difficulties that come from this. So these are some of the things that you could potentially tell patients to help ease their anxiety. In terms of obtaining a CT scan, I think every hospital now has CT scans, so they are commonly obtained, but there are some criteria from prior studies that really help suggest CT scans should be relegated to patients with more symptoms, older age or more risk factors. But oftentimes many patients get CT scans even with mild TBI, and that's fine. That's also helpful management. Moderate to severe TBI, I thought we could be focused on more within this talk. And in patients, these are defined as patients with a GCS of 3 to 8. That was 3 to 12, sorry, 8 to 12 being moderate TBI. So the first assessment that you essentially have for these types of patients are the ABC, sort of the assessment of airway, breathing, circulation. Oftentimes these traumas can be associated with polytrauma and other systems, so they require, a global assessment as to what has happened to a patient. Things that a neuro provider can do is assess the GCS early, hopefully before any sedation is given, brainstem reflexes, including pupil reactivity, getting a good inventory as to prior substances the patient's been on, anticoagulation use, and the mechanism and force of the injury. In CT head is sort of the first line of therapy, and then the CTA or CTV is indicated if there's fractures or injury that go across vasculature. MRI is really something we use in a delayed fashion, specifically in severe TBI to help with prognostication, not something we use in an acute fashion. What are things you can immediately do for patients with severe TBI? Elevate the head. This is commonly something we teach our residents. This is safe to do. You can Trendelenburg a bed even if you have to keep someone's spine precautions. There are studies that show that increasing the head of bed to 30 degrees reduces ICP. That's well established. Hyperventilation, to bring end tidal down below 30 is just used transiently if you need to get someone to the OR. Seizure prophylaxis, the guidelines still trying to debate about this use for about 1 week. Keppra is commonly used. You can sort of choose whichever medication you want. Hyperosmolar therapy, again, sort of a temporizing measure, medical induced coma, the last resort for ICP. And we'll talk about some of the studies that had talked about ICP management versus decompression and sort of what they've shown so far. And therapeutic cooling is something that has mixed results in the TBI population. It's used with cardiac patients who've had STEMIs, but much less effective in the TBI population. Here's some examples of well-known patterns of TBI that are important to recognize. Epidural hematoma, this sort of lancet moon-shaped pattern, commonly in this location on temporal bone, commonly seen in younger patients and more concerning in younger patients because of a tear in the middle meningeal artery that requires acute treatment. Subdural hematomas look very different. They can oftentimes cross sutures. They require higher force of injury, oftentimes associated with higher force of injury, so more concerning. Intraparenchymal hemorrhages can be seen. Newer studies we don't really have time to talk about, really talk about the evacuation of intraparenchymal hemorrhages and the benefits that they have in select populations. So this is an emerging field. And the traumatic subarachnoid hemorrhage oftentimes has to be sort of, the one thing that is really exciting with the GNI team is that they have a large group of vascular surgeons. And so I don't need to teach them anything about subarachnoid hemorrhage. It's a great group. And so what's interesting about traumatic subarachnoid hemorrhage is oftentimes you have to ask the question, did this patient have an aneurysm or some sort of vascular lesion cause this injury, or is this something that was due to the trauma? And oftentimes that needs to be ruled out. So mechanisms for spinal cord and traumatic brain injury are very similar. We think about primary injury as the initial impact, often rotational injury, shearing at the great white matter junction brainstem, penetrating trauma. And then secondary injury is what we try to treat and prevent later on. These are hypoxic inflammatory events that occur after primary injury, and they occur in the weeks to months after primary injury. And there are various mechanisms by how this happens, sort of circled here: disruption of blood-brain barrier, activation of the immune system, inflammatory pathways, and then programmed cell death or apoptosis. Various ways are used to define traumatic brain injury. GCS is kind of our gold standard. It has a high inner observer reliability. It's often used to quickly communicate with another individual, sort of what is going on. Declines in GCS are very sensitive to detect changes in a patient's neurological exam and prompt someone to go to the OR. The motor component of the exam is also sort of the best. It's the most sensitive for detecting exactly kind of what's going on with the patient. So there are various ways of defining kind of mild, moderate, and severe TBI based on GCS. The herniation syndromes, I think, are important to recognize. These are often things we have to teach to our colleagues in healthcare, because the neurosurgeons, I think, see a lot of this, but other colleagues may not exactly recognize these as quickly. Uncal herniation is something we worry about. It's common with temporal lesions, some sort of compressive lesion causing the uncus to compress on the brainstem. One of the early things you see is ipsilateral pupillary dilation from compression of the third nerve and contralateral weakness, but you can have false localizing signs as well. Anytime there's pupillary asymmetry in a patient with traumatic brain injury, you have to have a very clear reason for what that is. And pupillary asymmetry, especially with someone who has a declining GCS, that's when all the red flags go up. Someone that's talking to you that has an asymmetric pupil, there's got to be something else going on. So you got to think about that more. Downward herniation is kind of all these pathways that push down. It's oftentimes irreversible if that's happened, but it's something to recognize. And these are some of the other patterns: subfalcine, transcalvario. And then I wanted to put upward herniation, tonsillar herniation. Sort of posterior fossa lesions can be very dangerous. These are not areas that have a lot of space, and just a little bit of volume can cause a lot of compression and can be life-threatening for a patient, can cause obstructive hydrocephalus. But oftentimes, even patients with very low GCS have a posterior fossa lesion, have dramatic improvement with surgical intervention. So these are not patients at discount, but they should be recognized as a important category. For the neurologists in the group, I thought this is always interesting. This is something we teach for the boards, but we're looking at the motor exam and trying to understand why this can be really sensitive for detecting traumatic brain injury. The lesions in relationship to the red nucleus and vestibular nucleus oftentimes portend kind of important change in the motor function. So the lesion sort of below the red nucleus causes activation, excessive activation of the vestibular system, and the extensor postures dominate, versus a lesion above the red nucleus correlates with the decorticate posture. So this higher lesion of decorticate posture is, worse prognosis. The extensor lesion is. So those are things to kind of think about. The Marshall classification is something that's classically been looked at in neurosurgery to help identify kind of high risk patients, and these have to do with essentially the amount of hemorrhage on a scan as well as compression of the scan. So it's not something that I think we use to communicate patient to patient exactly what's going on, but it's a great way to kind of think about, how a scan looks and how that the risk of that patient. Patients may have even mild amounts of hemorrhage with compression of the cisterns, and there's a lot of DAI and other things you may not see on an initial CT scan. So it's sometimes not straightforward on a CT scan what the prognosis of the patient looks like, but this classification can be helpful to get an idea. The Brain Trauma Foundation, on its 4th edition now, has a variety of different categories where they've really tried to synthesize all the literature that's out there on how to manage these patients. And they do give the best recommendations based on the available evidence. I think if you haven't had a chance to read through these, it's worth going through, because it's very helpful in knowing everything, step by step in greater detail than just this talk. But there are still lots of gaps of knowledge, and this is not a perfect thing. Generally, what the Traumatic Brain Foundation talks about in terms of indications for monitoring are these. So patients with GCS between 3 to 8, abnormal CT scan. There's another study basically essentially showing patients greater than 40 with posturing or low SVP also benefited from a monitor. But for the most part, this first indication, someone less than GCS 8, really is where the ICP monitors are used. And then decompression indications really vary. They vary depending on the pattern of bleeding. They depend on many other factors. Generally, they are used for patients with declining GCS, hematomas that are greater than 1 centimeter in thickness, midline shift that's greater than 5 millimeters, cerebral edema. And this is really important. No other polytrauma. Patients that have other vascular or airway issues really aren't stable enough to go for decompressive hemicraniectomy, and so those are things that have to be noted. Neuroprotection agents, these have been looked at. They're still being looked at in the literature. There's nothing out there that is, class 1 evidence or anything that is regularly used. So these are still active areas of investigation. And just to highlight some of the updates from a 2020 update in the TBI guidelines, based on some newer studies that we'll talk about. The guidelines talked about secondary decompressive hemicraniectomy is performed for late ICP evaluation can improve mortality and favorable outcomes. They don't recommend it for early refractory ICP if you've not maximized your medical management yet. They reemphasize that a large decompressive hemicraniectomy greater than 15 centimeters in diameter is recommended. And there are newer studies that really talk about how decompressive hemicraniectomy can reduce ICP and duration of ICU care, but it's unclear whether these necessarily benefit outcomes. So we'll talk about those studies. These are just a highlight of some of the studies that are ongoing at our site that I've been involved with, and sort of the increase in number over time. These are a variety of TBI as well as vascular studies that have been really interesting to kind of be a part of. Some of the really important studies in this group that are very recent are shown here. So I don't want to go in great detail over all of them, but the ones that I wanted to highlight were kind of the DECRA study and the rescue ICP. These were, the DECRA study was one that was looking at randomizing patients who received bifrontal decompression versus medical therapy, and unfortunately didn't show a difference in mortality, and actually showed that the outcome scores were worse in the surgical patients. The decompression did reduce length of stay, and this would argue against decompressive hemicraniectomy, but the criticism of this paper is that, first of all, they're using bifrontal decompression, which has a little bit less benefit than unilateral hemicraniectomy. And second of all, there was very sort of unclear guidelines as to whether they had maximized medical care before doing the decompression and sort of the timing of it. So this is a study that's really important with this field because it's a randomized trial, but it also has a lot of criticism that it may not be real world, sort of how people use this. The rescue ICP was very interesting. They looked at patients randomized to medical therapy versus decompression. They showed lower mortality in patients with decompression, but higher vegetative and disabled states. This, I think, suggests that decompression can help reduce ICPs, help reduce ICU length of stay, but ultimately the primary disease, the mechanism, the force of that injury really probably impact the outcome. So, those are things that you could use to counsel patients. Oftentimes it's very hard within an emergent fashion to have that conversation. So this is still very difficult to figure out which patients will benefit from decompression and which won't in some situations. And then there are two other studies I wanted to talk about. One was the Global Neurotrauma Research Group. This is an international group that randomized patients ICP monitors versus expected management. Didn't show any difference in outcome. I think this means, and this is something that can be used for your practice, is when you get these patients with traumatic brain injury and you don't have time or an ability to put an ICP monitor, doing expected management with hypertonic saline, transient hyperventilation, sort of getting them stabilized can benefit these patients. So even without a monitor, there's things that can be done that could potentially be helpful for patients. And then the CRASH-3 study was a really neat study that looked at 12,000 patients randomized to receive tranexamic acid that helps prevent fibrinolysis and versus placebo, and showed no difference in injury risk, but reduced risk of hemorrhage, expansion, and reduced risk, better outcomes in mild TBI with no adverse outcomes. So in patients that you have that you think are there are anticoagulation, or you suspect there's coagulopathy, or there's significant hemorrhage, TXA could be a very safe drug to use. This can impact your practice potentially. There still needs to be more studies on it, but it's an interesting thing to think about. Some of the other newer studies some of these are ongoing. The TRACK TBI published several papers based off of their registry of traumatic brain injury patients, basically looking at mild TBI and moderate TBI. I just wanted to highlight one thing on the moderate to severe TBI, basically showing that in 12% of severe and 41% of moderate TBI patients, there were favorable outcomes at 2 weeks. And then this expands to 50%, 75% at 1 year. So I think it makes it difficult when you have a moderate to severe TBI patient coming in to tell a family, hey, this person isn't going to do well. It's in some situations you can tell, and some situations I think it's a gray zone. And there's not a lot of great information out there on how do you distinguish in that gray zone which patients you should really fight for and which ones may be beneficial to sort of ease off. So I think this information can be helpful to give hope to your patients, and I think have that conversation with them. The BOOST trials I've been a part of, and these are interesting because they use Lycox brain oxygenation monitor. The Boost 2 trial was a randomized trial looking at ICP versus ICP and plus Lycox. Basically, a small study, didn't show any adverse events, didn't show any difference in outcomes or sort of recovery between the two, but there were sort of, there was no protocol really on how to use the Lycox. I remember doing this as a resident, and we nicknamed these random number generators because we're just learning about the device and learning how to use it. And it was very frustrating because there weren't clear guidelines on exactly how do you intervene to improve these numbers and improve patient care. So I'm really excited to see the Boost 3 trial. This is sort of the extension of this. It's a multi-center randomized trial where you're blinded to the ICP versus ICP plus Lycox. You basically, you can see the ICP numbers, but some patients, every patient gets a Lycox, and in some situations you see the Lycox number and others you don't. So you're really just treating the Lycox number and doing the rest of your ICP management. The great thing about Boost 3 is they have very clear guidelines on exactly the interventions you should be doing for these different scenarios and kind of the step-by-step tiered approach, which I think is great. And everything is carefully documented. So it's really gonna, once this study is done, it's really gonna help us figure out whether Lycox monitoring is helpful for patients. The big studies, these are a variety of newer studies that are coming out from different centers where people are trying to better look at whether you could reduce the sort of the aggressiveness of treatment, especially in a time when, you know, CT scanners are limited, there's limited healthcare resources. Are there ways that we can identify mild TBI that don't require CT scans, don't require immediate follow-up or neurosurgical consultation, so you can save resources for other patients? And this was the first study that came out with this, but there are dozens of other ones where people have looked at these sort of classifications to help reduce the risk of patient outcome and reduce medical intervention. And so this initial study had looked at these three categories. On my next slide, I sort of show how they define these three different categories. I think these are neat because you can start to think about, you know, some of the milder injuries. A lot of times you get outside providers calling, you know, what do I do with this patient? Should I send them up? Do I need a repeat CT scan? These can be really helpful studies that help to identify what do you do with those patients with the mild TBI? Do they even need to see neurosurgery or get repeat scans? Right now, a lot of times people use kind of their own intuition and experience. Sometimes there are guidelines to help this. I think that the series of big papers that are going to come out are going to be very helpful in knowing very confidently which patients are going to need neurosurgical intervention and which ones you can sort of just observe and not worry about so much. Just to re-highlight the Boost 3 trials, these are sort of the sites that are doing this study. This is what a bolt looks like. There are various ways to place these Lycox monitors, and these categories basically where you have ICP numbers. 22 is now kind of thought of as the number that you want to treat for ICP elevation, and PbO2. So ideally you want to have less than 22 and greater than 20 here. This is kind of the sweet spot you want to keep patients. And this study basically had protocols for whenever patients fall into these other categories, what do you do exactly? This is a recent study looking at, you know, other randomized trials, other clinical trials in traumatic brain injury, not always randomized. They showed that there were 362 trials as of December 2021. Most of these involved, or many of these involved drugs. You know, 125 of them, 125 different drugs were used. And amongst the different drugs, there were really 7 different drugs or treatments. I guess you can't call hyperbaric oxygen a drug, but 7 different treatments that really had the most number of studies. I think the most interest is on these studies, a combination of neuroprotective agents as well as tranexamic acid we're talking about to help reduce risk of bleeding and improve prognosis. So just something to think about. Now to sort of transition to spinal cord injury, this is another area of interest of mine. You know, I think these are things you can have dramatic impact on patients' lives. These are some of my cases I wanted to show. Spinal cord injury basically is an emerging and continually worsening kind of disease globally. You know, in the US, we have about 12,000 cases annually, and about 4,500, 5,000 of these cases don't even make it to the hospital. We don't have even clear numbers. Many of these patients get treated in the community in rural areas. We don't hear about them. They don't become part of registries. So it's hard to know the exact numbers for this disease. Most injuries occur in the cervical spine, but injuries can occur anywhere in the spine. Motor vehicle accidents are the most common cause and often more common in young adults versus falls, about 20% of incidents and more common in the elderly. So again, similar to traumatic brain injury, there's this primary and secondary injury that occurs after a spinal cord injury. The first being from the mechanism, and the second being from inflammation, hypoxia, and other insults that occur in the weeks and months after. So those are the secondary injuries, what we really try to reduce with our treatments. In terms of spinal cord anatomy, there's various tracts that run up and down the spinal cord, but in terms of what we can actually quickly detect and treat on patients, it's really these three, light touch, pain, motor response, and proprioception. And so these are the different tracts that we evaluate. It's great to break down injury by upper motor neuron signs, to help localize a lesion. Upper motor neuron injury basically means an injury in the brain or spine. These patients can be flaccid initially, but over time they become spastic with increased hyperreflexivity. We're often requiring spasticity treatment, baclofen pumps, and other things to help treat that. Versus a lower motor neuron injury, these are peripheral nerve injuries. Patients become flaccid at the time of injury and they remain that way. And so distinguishing these two can be helpful with localizing lesions, both in acute and chronic spinal cord injury. The American Spinal Injury Association really helps set some of the guidelines for this. And this is a rubric that they use for the careful classification of spinal cord injury by level and pathology. These are not often something we use in a day-to-day clinical sense, but they can be very useful for evaluating kind of levels of injury. They can be very useful for pre-op and post-op or rehabilitation to see how patients are improving. And there's complicated scoring system that you can use for this, but most people just sort of break down these grades into these 5 categories, sort of AIS grade A through E, with A being complete injury, no motor or sensory response, E being normal, B being a person who is sensory incomplete, but motor complete. So they have no motor function, but they have some sensory function. And then C and D basically have to do with whether you have greater than 50% of your muscles with a strength, around 3, less than 3 or greater than 3. So the other critical part about a grade C injury is that it's sacral sparing. This is really important for prognostication. So I think getting evaluations of bladder function, rectal function, and sacral sensation are really critical for these patients because they really do affect prognosis for them. Some of the newer data about spinal cord injury that can be really helpful, I think, for counseling patients. And complete spinal injury occurs in about 30 to 60% of total spinal injuries. One thing that's always asked about when a patient has a complete spinal injury is my loved one, am I going to get any functional recovery? And the literature suggests that about 20 to 30% of AIS, basically complete injury, complete flaccid, no motor or sensory function, do improve to AIS B or C within 30 days, 50% to AIS B, 50% to AIS C. So there are groups of patients have substantial improvement even with the complete injury. So I think that can be information that can offer hope to patients, and it can be useful for counseling. There's better recovery in tetraplegia than quadriplegia. Interestingly, patients with injury in all 4 extremities, the literature suggests that they do better based on just different registries. The recovery may not be it'll probably never be completely back to normal, but someone who has improved function, even regardless of how much or the level, any improvement in function can help with ambulation, powering motorized chairs, using the internet. So there's those are little improvements, but they can have dramatic benefit for patients' outcome. And there's better recovery in lumbar injury and ironically worse recovery in upper thoracic injury. This is the most narrow part of the spinal cord. The cervical spine has better recovery than the upper thoracic spine. And a recovery after a year is unlikely. So this can be a time point you can sort of tell patients, hey, look, you'll have neurological improvement. It'll be quick at first, but then improvement will, taper off, plateau at about a year. These are some categories in the literature that have improved prognosis compared to others. So sacral sparing paraplegia with sensory preservation, some hip flexor preservation, and tetraplegia with motor preservation. So again, anytime there's sort of a unclear level, maybe is a way to think about this, or someone has some level of function, those can be really good prognostic factors. This is a summary kind of put together of these different injury levels, talking about sort of what percentage of injury there are, how many are potential to improve, and kind of how much they can improve. Obviously, the less severe the injury, the more likely that these will improve. The best motor recovery occurs within the 6 to 9 months, and it really plateaus at about a year out. These are some injury patterns which I thought could be helpful to recognize for people who aren't seeing these often. So transverse injury basically disrupts your vibration, pain, temperature, and motor sensation. Central cord injury oftentimes is described as this cape-like temperature and loss of sensation. Depending on the size of the injury, it can sort of result in more problems. It can result in dysfunction of the lower extremities, motor function as well, depending on kind of how big the lesion is. I was taught in medical school and in residency that it had to do with crossing fibers that really affect why it is that people get this distribution in the upper extremities. And some of the newer studies I've been looking at on this talk about instead it's the amount of motor representation of the motor and sensory representation of the human body. And it said that the upper extremity has greater disproportion of these fibers. And so lesions that are in the center often disproportionately affect the upper extremity versus lower extremity. So I thought it was interesting because it kind of changed my thought as to why this is occurring in the mechanisms. Brown-Séquard is a sort of injury pattern, oftentimes from penetrating trauma. Bullets and knives are often thought to cause these. They result in sort of ipsilateral loss of vibration, position, and sensation, but contralateral pain and temperature loss, something to recognize. Anterior and posterior cord syndrome have to do with the vascular supply. Basically, depending on which blood supply to get injured, you can have variations in sensory loss versus motor loss, depending on where that occurs. CAUDA syndrome, these are things oftentimes we get called about as neurosurgeons. In reality, I think that a true CAUDA is relatively rare. Here in Utah, we maybe treat emergent CAUDA, I'd say like three to 5 times a year, but we get called on it probably 50 times a year. So these are things you definitely don't want to discount, but you have to kind of take with a grain of salt a little bit, just because many other providers maybe not recognize, they're not commonly seeing these pathologies. They don't know when is it emergent or not. So they're calling it sometimes when it's not. And with a true CAUDA equina, it isn't an emergency. It can be from trauma or herniated disc. Compression of the nerve roots can start affecting bowel bladder function, sensory functions. People get saddle anesthesia. Usually it's unilateral, but it doesn't have to be. And the CONUS medullaris syndrome is also a related pathology, oftentimes very similar to CAUDA equina, but more commonly these show bilateral issues. Both of these are neurological emergencies because they can result in irreversible injury if not treated surgically acutely. How do you manage patients with spinal cord injury? Very similar to traumatic brain injury. First, you sort of stabilize a patient, brace them, and go through your ABCs, make sure you evaluate their polytrauma. CT imaging can be oftentimes very helpful to be able to quickly identify what the injury pattern looks like. And MRIs can be used depending on how much time you have for a patient. So the goal for the goal of immobilization is to help sort of prevent other secondary injuries, other sort of bone fragments, discs, or things compressing the spinal cord. And it's always better to immobilize the spine until an injury is ruled out. Here's some quick and dirty ways to kind of look at spine alignments with different lines that are sort of indicated here, as well as the ligaments that they support. The more of these that are disrupted, the more unstable a spine is. This can be helpful up and down a spine. It's a very quick and dirty way to kind of look at what a patient's spine looks like. These are different ways of immobilizing patients. Obviously, many of you have seen these before. And bracing is typically used for mild injuries. It's not really effective for severe unstable injuries. And there's a whole, we could talk about bracing for an hour because there's a whole field of as to when do you use these for how long, and these are often had for more mild injuries. There are different classification systems for identifying when someone has spine instability and needs to go for decompression or for stabilization. So the GNI classification has been one that's been really useful. I think it's simple. Basically, they split the spinal cord to 3 columns, the spine into 3 columns, anterior, middle, and posterior, depending on the different ligaments and the structures. And if you have disruption of 2 or more of these columns, then you have sort of instability. So that's a very simple way to look at it, but it gets certainly more complicated than that. Very clear surgical indications in spine are oftentimes things you can kind of, these are black and white, 3-column injuries, patients with neurological deficits or compression, significant canal compromise. The loss of height, I think, has been talked about, but that's not always the case if there's not compression of the spinal cord. And angular deformity, even if patients don't have neurological injuries, sometimes patients with angular deformity still require surgery because you're trying to prevent further deformity of the spine that can cause them problems down the line. More recently and more widely used is the AO classification of spine injury. So what this has done is broken down injuries into compression type injuries, distraction, and then these translation injuries shown here. So within the compression injuries, these become really easy ways to talk to other providers. Hey, this patient has an incomplete burst. The patient has a complete burst. Basically, the difference being if the posterior wall of the vertebral body is compromised, that's when you have a complete burst. But these can be very useful to talk to other providers, talk to patients about what's going on. Complete bursts don't always need surgical intervention either. So it really depends on sort of the level of deformity, height loss, other things like that, patients' morbidity and other factors. These translational injury, the distraction translational injuries, oftentimes these do need surgical intervention. They're much higher forces. They're much more destabling. You destabilize throughout multiple columns of the spine. So these are things that we commonly take patients to the OR for. The AANS and CNS wrote guidelines in 2013 talking about where the literature was for the management. And these were specifically focused on cervical spine. They have other guidelines talking about thoracic and lumbar injury, but cervical spine was a very nicely put together set of guidelines. And there they talked about maintaining mean arterial pressures for greater than 85-90 for a period of 7 days. I'd say the literature for that is not level 1. It's limited. There's a lot of great animal literature and other spinal cord injury literature that suggests that there's improvement from doing this. Many centers will do this, but it's still a bit controversial. Some of the newer studies talk about spinal cord perfusion pressure, especially now that the cardiothoracic surgeons are commonly using this when they're doing aortic surgeries. And so this is becoming much more interesting in spinal cord injury, and it really defines mean arterial pressure minus intrathecal pressure. We're not typically measuring intrathecal pressure with spinal cord injured patients. We're just sort of using map augmentation, and there's some studies that suggest perhaps we need to increase the maps even higher to 100 or more to be able to get the spinal cord perfusion that we're really looking for. When do you operate on patients with spinal cord injury? Well, one of the best studies I like to cite is this one from Mike Failing's group, who organized this in Toronto. This is the STASCUS trial. It involved 313 patients, 6 American centers were involved, and they basically looked at patients who underwent treatment early versus later. This is a really well put together registry of patients and with real experts in spinal cord injury, and basically showed if you were to operate on patients sooner, within 24 hours, about 20% showed an improvement of greater than 2 ASA grades within 6 months. So early treatment, basically you can see more of these, more black here. So you have improvement in your AIS scores. Certainly you're not going to randomize patients to receive early versus late treatment. This is just sort of a registry that talks about when patients could get in. And there are newer studies talking about even earlier treatment, but generally with spinal cord injury, it's something we kind of schedule for the next day, the first case of the morning. It's not something you have to crash in the middle of the night like a brain injury. And this is one of the main studies that kind of supports that. What about for central cord syndrome? This is becoming more of a common problem, especially in falls with the elderly. And this is a study published in JAMA, 186 patients comparing early versus late decompression. Again, early decompression was found to be beneficial, mostly for upper limb function at a year, and it showed the greatest difference in these AASC patients. So definitely a benefit of early decompression. Central cord is somewhat controversial whether you need to decompress it or not, but in those patients you selected to do that, then the earlier treatment seems to be beneficial. These are some of the medical treatments and other randomized clinical trials in spinal cord injury. I only put it up here just to always highlight the NASCUS trials for patients and for people that aren't as familiar with these. These are randomized trials looking at the impact of steroids with spinal cord injury. The use of steroids is also very controversial in the spinal cord injury literature. They use very high doses. The randomized trials suggested that there could be worsened outcome with steroid use because of risk of GI bleeds and infection. Ultimately, these studies weren't successful for their primary outcome of showing a benefit for steroids. It was really the secondary analysis which showed improvement if given within 8 hours of injury in this NASCUS-2 trial. And that's what's made it controversial, is you've got this potential subgroup of patients that could be benefited from this, but the study really wasn't powered to look at that. So that's where the controversy lies. And it's sort of the NASCUS-3 didn't really clear up that controversy very much at all. So we're still kind of up in the air whether to use steroids or not. These other studies oftentimes are looking at different anti-inflammatory treatments. Unfortunately, none of them have really been very successful in this group of patients. I wanted, with the last few minutes, just to talk about some of the newer research I've been involved with and just talk to you about that. So, chronic subdurals are something that we oftentimes deal with. These can occur after acute subdurals. And one of the problems we have with subdurals, and our group is a contributor to the membrane and embolyze trials, which are looking at embolization as a way of reducing recurrence with these patients. But one of the problems I found very early on with dealing with these was that traditional burr holes, when used to treat these, weren't very successful. They had high recurrence rate. You couldn't always get through these membranes. It was very difficult. And in order to get through these membranes, you might have needed a very big craniotomy. Oftentimes, these are elderly patients. You don't want to be taking them for large surgeries like that. So I started looking at whether more minimally invasive ways of doing this, and started getting interested in using the endoscope. And here are various sort of cuts of some of the cases we've done using the endoscope to help with subdural evacuation. And we're writing up this series currently to try to talk about some of our results. And we did a meta-analysis looking at the literature of this as well. But just to show a couple points of it, you can kind of see after a irrigation, our standard burr hole, whatever mini craniotomy, irrigation, maximal irrigation, this is the amount of clot that's left in this particular patient. And it's because they have membranes. It's very difficult to be able to get all these out. But with the endoscope, flexible instruments, you can kind of get back there and you can start to evacuate these a lot better. You can visualize drains that are placed. You can have drains enter into the brain if you're not careful. So visualizing is helpful. The straight suction could be used, but the malleable suction that we're using here is much more flexible, and it can cauterize as well. We've been starting to cauterize the membranes a lot more aggressively. You can take these bridging veins and prevent them from essentially causing problems. This is us cauterizing the undersurface, basically their skull underneath here, brains on the other side. So there can be ways that you could prevent some of the oozing that occurs with these patients. And I thought this is just a neat tool that could potentially help this group of patients, simply because I've been frustrated with the recurrences that we see with them. So this is a patient that had that bilateral endoscopic sort of treatment and kind of the benefit that they had. And we have other examples of that as well. We did a systematic review. We found 14 studies that are out there. We found that the overall recurrence rate in these studies ranged from a 0 to 8.8%, so about 4% on average, depending on the sample size. We typically quote patients a risk of about 20% recurrence rate with the chronic subdural drainage. I know there are studies that look at just twist drill burr holes or single burr holes or double burr holes for draining these, but there's still 20% risk of recurrence. And maybe the endoscope could be a way to kind of cut down that risk. Some of the limitations of it, it does require more equipment setup. It requires, it's a little bit more of a futz factor and it increases the length of time for the procedure. So there still needs to be more done to see if there's benefit for it, but it's something that is an easy tool that often sits in most hospitals that could be used. The MMA embolization, I think this is going to be very interesting as the randomized trials come out, membrane embolize, and there are others as well. And once those are completed, we're really going to know the benefit and the particular patients that this is going to be useful for as well. So this is kind of an interesting area of research. The last thing I wanted to talk about was some of the work we've been doing with augmented reality. There's a company, Novorad, that's based out in Utah that I've been able to collaborate with, which has been really, really neat to just get to know, how these devices are brought into the market. And this is originally a group that essentially did radiology packs and other kinds of radiology software. And now they're working on this AR technology for years now. It's cleared for spine intraoperative navigation as well as a pre-surgical planning. And we've been helping kind of improve the indications for cranial use. And you can see some discussion of kind of how the workflow works. The footprint is basically just the headset. This is kind of what you see when you're looking through the glasses themselves. These are registration tags. This is a study that I'll talk about where we're looking at targeting the ventricles and we'll talk about some of the data, but this is kind of what you get to see when you're looking through that. Neurosurgical applications of AR neurosurgery are incredible and immense. I think that they could be used for a variety of different things, planning craniotomies, helping with intraoperative surgical use. It's more intuitive to understand the imaging rather than a 2D image that we currently use with Stealth. You can add multiple modalities. You could potentially help train our residents and fellows faster because they can recognize the data, and you could teach patients and families as well. So there's a lot of benefits for using this. We did a study basically looking at augmented reality-based EVD placements. So external ventricular drains used for reducing intracranial pressure and measuring intracranial pressure. We basically did 2 phantom models as well as a cadaver model and tried to look at the accuracy of augmented reality in helping target these ventricles. There are different ways we sort of measure this. We did CT comparisons. We used Axiom as a gold standard as well. Basically, we found about a 1 millimeter error when using CT to measure targeting the ventricles, shown here. So sort of the 1 millimeter error, 1 degree error. And then when looking at Axiom, we had a bunch of our residents, the medical students, come through and start using this and see how well they did. Basically, Axiom has its own sort of internal error, so you have to add that. So we basically overall found about a 4 millimeter level of error. We didn't see any difference in accuracy depending on PGY level, experience with augmented reality, EVDs, or video games, which is interesting that you can get a medical student here that can basically place an EVD. He's never seen an EVD or knows what to do with it, but you can just follow the dots and you can place this EVD compared to senior attendings and other people. They basically are getting equivalent outcomes. So I think this technology is neat because it potentially could flatten learning curve for a lot of these procedures. This is the examples of 2 of our residents placing these different techniques they tried using. Basically an example of the Axiom where we sort of placed it. This is kind of, I have my volume up here. This is sort of what the cadaver looked like. On the cadaver, we compared traditional anatomical landmarks, our typical Coker's point and Fraser's point, modified Fraser's point, and basically we found about a 1 centimeter level of error for each of these different trajectories. And in patients with big ventricles, you're going to get the ventricle, you're not going to miss it. But what we could potentially do with augmented reality is reduce that down to 4 millimeters. And that's where the benefit could come in. The footprint is smaller, so you could take these into the ICU or ER. You could take them into maybe hospitals that don't have image guidance. So there's a lot of potential ideas for where this could be really useful. Overall, I'd like to just thank sort of the different team members I work with here at the U, as well as with Novorad, some of the funding sources for that are doing the TBI and vascular trials. Wanted to thank the the group at GNI for the invitation to come speak. It's really exciting to be able to join a group of really just sort of broad, diverse, and really interesting people that I've heard a lot about, and I'm looking forward to it. I think it's going to be exciting. I can't wait. So thank you guys so much for your time and attention.
Thank you, Michael. That was wonderful. What a great lecture and grand rounds. We're all so excited for you to join us. I have a question with you that AR, which is I think is just unbelievably fascinating. And as you said, the only downside is that means everybody can put in an EVD and it's no longer needs to be specialized. But so that's not used in concert with image guidance. How is a projection of the ventricles that is the patient's ventricles portrayed into or on your AR?
Yeah, so that's a great question. So the idea with AR is that you're essentially replacing image guidance, or it becomes the next generation of image guidance. The patient's DICOM images, their direct DICOM images, can get loaded into that system, and then there's software to be able to map that hologram that you create to a patient. You can use these tags to do it. You can do point-to-point registration for people that are familiar with how other neuronavigations work, and you can essentially register your 3D volume DICOM image to the patient's head or spine, and then it could track that patient because you have these tags, or you've pinned the head, or whatever different mechanism you want. And then the way to localize the ventricles, for the experiments, we had segmented the ventricles to have them kind of as a 3D hologram. But what we also did was essentially use unsegmented images, where you can sort of scroll through the axial image and kind of find that trajectory and sort of know kind of, I got to go in this direction, or I can line up my bullseye and go in this direction down towards the ventricle. The company has been working on essentially a AI-driven algorithm to help segment these ventricles also. So that's data I didn't show you, but they have a way that you can load these images, and their AI algorithm can segment the ventricles into a hologram for you as well. So lots of different kind of things you can do with this. And again, I hope that there aren't non-neurosurgeons kind of offended or that they wouldn't be doing this. In Philadelphia is great because you have incredible resources and a lot of people in one area, but there's going to be rural Pennsylvania, just like there's rural Utah, where I'm sure you've seen patients come in that could have used an EVD hours ago. That's where I think this could be helpful for. I have also a friend who's in the Navy, and he is sort of looking at AR technologies for the military. You have these people that are overseas that you have a CT scanner, but you don't have the expertise in field, in theater. So you can use AR to understand anatomy, potentially liaison with physicians back in the US to be able to do procedures. So there's lots of applications beyond just sort of our, I think, traditional neuronavigation.
Thank you. Let me see any other questions we have. I also have additional questions. Just the research that you presented about TBI and hemicraniectomies. Can you clarify that those are not patients, or the question is, did they include patients with true space occupying lesions like either extraaxial blood or intraaxial contusions, blood, etc.?
No, it's a great question. The Traumatic Brain Injury Foundation kind of looks at every study, and so you're going to have a mix of different heterogeneous patients, but the TRACK TBI did a much better job, I think, of looking at patients with intraaxial lesions. They had strict criteria for who was going to be enrolled in those registries. So the moderate and severe TBIs are that's why I present those studies, and I think they're really good. I think they're good real world examples of the kinds of patients that we treat. And those registries are run by neurosurgeons. They have a good idea as to what we're interested in. So I think that presents the best prospective data that suggests there's benefit with severe TBI. Now, we put in a proposal with them to look at, can we, ask exactly your question. Could you better separate out patients with different volume hemorrhages, whether these are intraparenchymal traumatic, subdural, epidural, what you could separate the pattern out a little bit more to see, that those gray zone of patients where you don't know if they're going to do well or not. Could we delineate that a little bit better? We sort of yet to hear back from the track TBI people. I think they're busy with other projects, but I think that's one of the next steps with that prospective registry that they created.
Thank you. Well, that again, I just can't thank you enough. It was really wonderful, and I look forward to seeing you in person.
Likewise. Thank you guys so much for having me. I'm super excited to meet all of you.
Great. Thank you again, Michael. Take
All right.
care.